All right, so please make sure you've got handouts with you. If you don't have them, if people could share with those close to you. At the end, we're going to go through a number of questions that helps you really put all this material together, and you'll really need the handouts. This includes those of you watching from my awesome YouTube channel. You got 3 handouts that you should have. One of them is just a listing of the different controller medications and what is considered low, medium, and high dose according to age. You should also have one showing your measurements of severity and control, and one going through the different steps in therapy. So make sure that you've got all 3. So objectives for this 2-part series. One, we're going to go through basic epidemiology and pathophysiology of asthma. Make sure you guys are comfortable with diagnosing it at different age groups, know how to assess severity and control, and be able to correctly classify asthma according to the guidelines and prescribe medications according to the guidelines. One of my favorite things about lecturing about asthma is that the guidelines for how we manage it have not changed since 2007. So that's great. I don't have to update this that much. Unlike hypertension, we've changed the diagnosis of hypertension and how to treat it about 4 or 5 different times in that time frame. This dates back to 2007. In part 2 next week, we're really going to focus on management of asthma exacerbation, as well as exercise-induced bronchospasm, and touch a little bit on action plans. Today, we're going to primarily focus on how to correctly categorize it and manage it chronically in the office setting. All right? So first, a little epidemiology. Around 8% of adults and a little over 8% of U.S. children have asthma. This is according to the CDC's numbers in 2017. Asthma is the primary diagnosis for about 17 million outpatient physician visits annually, and it's the primary diagnosis for nearly 500,000 hospital discharges annually. So we see a fair amount of it. It's the most prevalent chronic condition in childhood, number 1 cause of missed school in kids, and number 3 cause of hospitalization in kids, and it disproportionately affects African American and Native American children. So basic pathophysiology. This has implications for what medications we use to treat it. 2 main things going on: abnormal airway smooth muscle function. Your beta agonists primarily target this, and airway inflammation. Your corticosteroids and leukotriene receptor antagonists primarily target this. So both these things are going on at the same time. This is why combination therapy is needed for most individuals with asthma. All right. Basic presentation, how these people come in. You see intermittent dyspnea, cough, wheezing, some nonspecific symptoms. Asthma patients often have a cough that's worse at night. If you press them, they may note some characteristic triggers like exercise, cold air, exposure to certain allergens, dusts, molds, pets, cockroaches, pollens, things like that. And we know that getting at a diagnosis isn't always straightforward. Lots of people wheeze. Not everyone who wheezes has asthma. Usually this is diagnosed in childhood. More than 3/4 of the time, you're going to diagnose it before the age of 7. But the differential for wheezing is pretty broad. Allergies, asthma, GERD, viral infections, a foreign body can make you wheeze. Cystic fibrosis, vocal cord dysfunction. Look for a pattern of wheezing. Is it episodic? Is it constant? So we're going to break down how to diagnose based on different age groups and what tools you have available. Children age 0 to 4 are usually the toughest to diagnose. We see a lot of wheezing in this age group, oftentimes in conjunction with a viral illness. And one of your most useful diagnostic tools, spirometry, usually can't be performed. Maybe you have a really elite, intelligent 4-year-old that can do it, but generally you can't do spirometry in this age group. One of your tools that you can use to help diagnose is something called the Asthma Predictive Index. Is anyone familiar with this? I see mostly no's. But it's based on the identification of risk factors in the first 3 years of life and it can predict wheezing that's going to last into the school age years. So this is useful for when there is recurrent wheezing, some other specific criteria. So a positive asthma predictive index is defined as recurrent wheezing plus some of these things we have listed here. So there's the major criteria. So recurrent wheezing plus asthma in a parent or physician-diagnosed eczema. Or there are minor criteria. Recurrent wheezing plus either physician-diagnosed allergic rhinitis, wheezing without colds, or peripheral eosinophilia on a blood count. If you meet those criteria, either one major or two minor in the setting of a child who you've seen with recurrent wheezing, if you have those, you have a positive API and a greater than 3/4 chance they're going to actively have asthma during the school years. If you have a negative API, they have less than a 5% chance of having active asthma during their school years. So a negative API is pretty useful in telling who's not going to have asthma in this age group. A positive API is fairly useful. So age 0 to 4, you're primarily relying on symptoms and risk factors. And the NAEPP guidelines encourage you to start control or therapy if you see a positive API and at least 4 wheezing episodes in the past year. And that's whether or not they're associated with a viral illness. If you got a positive API and they've been reported to be wheezing 4 times, maybe they went to urgent care, maybe parents reported wheezing, maybe they're wheezing in the office, or if they've had 2 episodes where they've had oral corticosteroids in the past 6 months. It's a lot to remember, so I would encourage you to know the term asthma predictive index and know how to look that up when you're seeing a child under the age of 4 where you're concerned with asthma. A lot of what I want you guys to have out of this lecture is the knowing where to look. I don't expect you to memorize all of these guidelines. Kids 5 to 11, you've got your handouts in front of you, or most of you do. I should have printed closer to 30 copies. I thought I made enough. Children ages 5 to 11, you should perform spirometry in all children age 5 and up if you're considering the diagnosis of asthma. You do need to take into account the skills and abilities of your 5 and 6-year-olds. I think some kids can do it fine, many cannot. Spirometry, this should be basic spirometry. You don't need complete PFTs, but basic spirometry to include FEV1 and an FEV1 to FVC ratio. Airflow obstruction is defined as an FEV1 less than 80% of predicted, or an FEV1 to FVC ratio less than 85% of predicted. Remember, asthma, bronchospasm slows down how quickly you can get the air out. Your FEV1 to your FVC ratio is your most sensitive spirometry tool for diagnosing asthma. To make a diagnosis of asthma, they should also have reversibility. This is a real key component in adults with distinguishing asthma from COPD. Kids, you're not going to diagnose COPD, obviously, in the 5 to 11 group. You're going to be diagnosing asthma. They should have reversibility, which is defined as an increase in FEV1 by at least 12% after administration of a short-acting beta agonist. If you look at your handouts, it has your classification. You have these FEV1 and FVC ratios on there as part of your diagnosis. So we use peak flow a fair amount with monitoring. The guidelines encourage you not to use peak flow for diagnosis of asthma, but you can use it in monitoring response to treatment and in self-monitoring asthma when you're designing asthma action plans. So an important concept to know about spirometry and asthma is that when your patient is not exacerbating, and if they are medically optimized, how should their spirometry look? Should it look bad? Should it look normal? It should look normal, right? Asthma is a condition where spirometry is going to change. If they're not exacerbating and they're medically optimized, you can't rule out asthma with normal spirometry. So you want their spirometry to be normal when they're healthy. So if spirometry is normal and you're trying to diagnose it, what else can you do? If you really suspect they have asthma despite normal spirometry, you can do bronchoprovocation in the PFT lab with a methacholine challenge test. Or what I more often do in kids is a trial of a controller medication or a trial of a short-acting beta agonist and assess their response to treatment. Then I'll oftentimes, if they are, close to an exacerbation, or if they are exacerbating and they're, but they're not like desperate for air, you can PFT them then to get to your diagnosis. All right, adults and children ages 12 and up, spirometry is strongly recommended for diagnosis, and with pre and post short-acting beta agonist testing. Same measures as for airflow obstruction and reversibility as the 5 to 11 group. You'll notice in your handouts that with increasing age, so 12 is the cutoff for adults in asthma, and above age 12, adults are thrown into the same group. So, but as adults get into their 30s, 40s, 50s, 60s, there are decreases in lung elasticity, so the normal FEV1 and FEV1 to FVC ratios will decrease. That is reflected in those handouts that I gave you. I really just want you to know these numbers for your 12 and up young adults. And once again, if initial PFTs are normal in this age group, consider the bronchoprovocation testing, consider repeating PFTs when the patients are symptomatic, and then consider repeating them over time, possibly with the trial of a short-acting beta agonist. All right, do you guys have questions about diagnosis before we move on to classification? Very good. Couple of slides on categorization. There's these concepts, I think if you're not looking at how we categorize and looking at the guidelines and steps in therapy, I think that this can be a little bit abstract. It makes sense, and it'll make a lot of sense at the end, I think, when we look at some case scenarios. So there's two domains for classifying asthma: severity and control. Severity is the intrinsic intensity of the disease. Looking at asthma patients, some people exacerbate worse than others. There is an intrinsic intensity to it that varies from patient to patient. Asthma control is the degree to which the manifestations of asthma are minimized. How good of a job do we do in helping our patients control it? Patterns of utilization, so coming into the office, ER stays, hospital stays, tend to correlate more closely actually with control than with innate severity. The goal of asthma treatment is to reduce current impairment and future risk. So you see these are kind of your domains of severity and control are the impairment and risk. And if you're looking at your guidelines, that'll make a little bit more sense. So impairment and risk, they're the two components of severity and control. Impairment is how much are they currently wheezing, having nighttime cough? How much are they currently using their short-acting beta agonist? How much does it interfere with normal activity? What do their PFTs look like right now? Those are their measures of impairment. And then risk is how sick do they get? So, which is defined as exacerbations requiring systemic corticosteroids. If they've had to use systemic corticosteroids more than 2 times in the past year, that's a higher risk patient. A question you should be asking all of your patients in the hospital who are there for asthma: have you had to go to an ICU? Have you been intubated? Patients who answer yes to those questions are much higher risk, even if their current impairment is very low. And when you're classifying a patient, you classify them according to what is the most severe component of your assessment. So if their nighttime symptoms are just fine, they're not using their short-acting beta agonist a lot, but their PFTs are bad, you categorize them according to what's worse. If their impairment's really minimal, but they've had 4 exacerbations where they've had to get systemic steroids in the past year, you classify them according to that. You guys are looking at your guidelines, does that make sense? When you're deciding where to place them, you go with what component of their presentation is the most severe. All right. Categorizing. We categorize asthma based as either intermittent or persistent. And then within persistent, there's mild, moderate, and severe. There used to be mild intermittent and different stages of intermittent, but the guidelines from 2007 on really recognize that intermittent asthma can have just about any level of severity, so that mild intermittent is gone. There's just intermittent, persistent, and then within persistent, there is mild, moderate, and severe. And those classifications correlate with recommended steps in therapy. Asthma control is classified as well-controlled, not well-controlled, or very poorly controlled, and that correlates with recommending a step up in therapy, maintaining current therapy, or stepping down therapy. And then a brief slide here that I added about asthma phenotypes. This is something I was reading on recently, and as I read on this, I thought it made a whole lot of sense because in practice, we really see our patients with asthma over time behave very differently. In a lot of patients, it goes away. In adult patients who carry a diagnosis of asthma, it's been suggested that as many as a third of them really no longer have the symptoms to meet a diagnosis of asthma. And there's different types of sort of phenotypes that make sense of that. There's transient early wheezing is one phenotype. Usually in these patients, symptoms are limited to age 3 to 5, and there's not a strong association with allergic sensitization. There are non-atopic wheezers. This has a strong association with early onset RSV. This phenotype of asthma, patients tend to wheeze up till their teenage years. They tend not to develop allergic sensitization and allergic rhinitis, and their asthma symptoms usually fade in teenage years and in adulthood. And then there's the classic IgE-mediated atopic asthma. This is the majority of our patients for whom asthma persists into adulthood. They have persistent wheezing, atopic derm, allergic rhinitis, and allergic sensitization. There's more research being done into how we should diagnose the different phenotypes and how we should treat them, but right now it doesn't really have implications for how we treat according to the NAEPP guidelines. Just something I really kind of thought was interesting as I did reading and updating for this, and definitely see these subtypes, within practice. All right, so what we're going to cover next on medical therapy is how to initiate and adjust long-term controller medications. And then in part 2, we're going to talk about how we treat exacerbations and how we treat EIB. All right, so turn on your eye clickers. True statements regarding long-acting beta agonists include which of the following? Pick one answer. Are they useful in treating acute symptoms? B, they're a useful substitute to inhaled steroids for long-term control. C, they're preferred add-on treatment in patients 12 and up. D, salmeterol acts more rapidly than formoterol. Or E, they are contraindicated in children under 5. Feel free to use your handouts to help you with that. All right, good. 100% of you got it right. C, they are the preferred add-on in step 3 treatment for pages 12 and up. Long-acting beta agonists can be used in children 5 through 11, though a medium dose inhaled steroid or leukotriene receptor antagonist are equal options rather than a preferred option. And long-acting beta agonists are options at step 4 in children under 5. Due to the delayed onset of action, especially with salmeterol, long-acting beta agonists are never recommended as your only controller therapy in asthma. There's a lot of overlap in asthma and COPD and the medications that we use, and there's only like 2 answers that are going to be wrong all the time if you use them this way. In asthma, it's never correct to use a long-acting beta agonist alone. A LABA alone is always wrong in asthma. And in COPD, an inhaled steroid alone is always wrong. All right, all the other combinations are okay somewhere in the treatment algorithms. Although in the 2007 guidelines, the long-acting antimuscarinics have not been added to asthma therapy, but they do have some usefulness. I don't cover them in this because they're not part of those guidelines. But know that if you ever see LABA alone in asthma, it's wrong. Inhaled corticosteroid alone in COPD, it's wrong. And then reason we don't use the long-acting beta agonists alone in asthma is they're going to treat that airway hyperreactivity and do nothing about the airway edema and inflammation. So, moving on. Next question. Eye clickers again. Which of the following statements are true regarding the leukotriene receptor antagonists? A, they can be used as quick relief agents. B, they're not effective in exercise-induced asthma. C, they're more effective than inhaled steroids in children under 5. D, they are contraindicated in patients with aspirin-sensitive asthma. Or E, they can be used as an alternative to LABAs for all age groups of patients with asthma. Which is correct about the leukotriene receptor antagonists? All right, most of you guys got it. It is E. They can be used as an alternative to long-acting beta agonists in all age groups. So they're an alternative therapy in mild persistent asthma at all ages, and they're also an adjunct in moderate persistent asthma, though they're not preferred compared to the long-acting beta agonists. Inhaled steroids are still preferred and more effective in children under 5, so I think that was option B that was incorrect. Something to know about the leukotriene receptor antagonists, they are particularly effective in aspirin-sensitive asthma, as well as exercise-induced steroids are still pretty expensive. Alrighty. So when you're looking at how to initiate therapy, you've got two main approaches, the step-up approach or the step-down approach. Our friend Austin Powers here is demonstrating the one that I would encourage you to use. The preferred approach is the step-down approach, which is to initiate therapy at a higher level to achieve quicker control and then step down. I'll give a case that I saw in the office just this week that helps make sense of this. Precepting, earlier this week we had a patient come in who is a long-term asthma patient, was not using any controller medication, and was using a short-acting beta agonist roughly 12 times a day. He was not actually wheezing in the office. He had normal pulse ox. He could walk without wheezing. He's in his mid-20s, otherwise healthy, but he's using it very frequently. So for a patient like that, I don't think it makes much sense to start at step 2 with a low-dose steroid and then see him back in a few weeks and see how much are you wheezing. You know, he's probably going to still be using his short-acting inhaler maybe 6 or 8 times a day. Makes more sense when you've got somebody who's more actively sick, start higher up, get him feeling better, and step back. So what we did for him, we initiated therapy at step 4. We put him on medium dose inhaled steroid plus long-acting beta agonist. We have a medium dose of Symbicort. See that patient back in 4 weeks and assess their response. Either option is correct, but step down I think makes a lot more sense. Your patients are going to be a little happier with you because they feel better more quickly. You could have argued we could have also given oral corticosteroids to that patient. He was breathing pretty comfortably in the office. We felt let's get him started on just the controller patients. So we're going to just run through the basics on each class of medication here. And then we'll go through a bunch of questions to help you guys really put together how to apply the guidelines to cases. So short-acting beta agonists, these are your most effective medicine for the rapid reversal of airflow obstruction. Main one we use is albuterol. There's also levoalbuterol and pure buterol, Max Air. Don't use Xopenex. I think the studies out there have really shown that it does not meaningfully reduce side effects in any way. That's how it was marketed to us. It was the L enantiomer of albuterol, and people are going to have less feeling jittery and less tachycardia. It's no different. Just use albuterol. With the short-acting beta agonist, the onset of action is very quick, 5 minutes or less, hits its peak effect in 30 to 60 minutes, and has a duration of action of 4 to 6 hours. So the guidelines recommend using it only as needed for symptom relief or before anticipated exposure to known triggers. You should not be telling your patients to use these on a set schedule for control. And like I mentioned, levoalbuterol has a side effect profile that is indistinguishable from albuterol. One, real important thing to mention to make sure your patients know. So you're going to write a prescription that's going to say, use every 4 hours as needed, use every 6 hours as needed. If they are really in trouble, use it as much as you need it. If you think about what happens when we have a patient come into the ER wheezing uncontrollably, we'll put them on continuous albuterol. But the last thing you want to have happen to an asthma patient is to have them die because they thought they could only take it every 4 hours. There have been cases about that. There have been lawsuits about that. So make sure your patients know if they're really in trouble, keep using it. They don't got to wait 4 hours for their next dose. They should get help if they're needing it that often too, but keep using it. All right, inhaled steroids. Inhaled steroids are the most potent and consistently effective long-term controller for asthma. They're so consistently effective that if your patient is not having a reduction in impairment from the inhaled steroids, you should really be entertaining alternative diagnoses too. For patients not adequately controlled with a low-dose inhaled steroid alone, the option to increase the dose should be given equal weighting to adding other adjunctive therapies to it. When you're using these, you see improved symptom scores, fewer exacerbations, less use of oral corticosteroids, and fewer hospitalizations. So use the corticosteroids. Know that, however, not all patients are going to benefit equally. Smokers tend to have a decrease in responsiveness, and some African American children are less sensitive to inhaled corticosteroids. And know that inhaled steroids have a delayed onset of action. So if you're having an exacerbation, they're really insufficient for control. You need to have the oral corticosteroids on board. In the past, for a while, we were including kicking up doses of inhaled steroids in action plans. That does not look to be effective. They work too slowly for that. Side effects: sore throat, coughing on inhalation, hoarse voice, and thrush. Make sure you warn your patients to rinse after use. So most inhaled steroids are twice daily medicines. What I encourage my patients to do is use them before they brush their teeth. Then they're going to wash everything out. They're going to get it out of their system. They're not going to get thrush from it. If your patient gets thrush from their inhaled steroid, they're going to be really ticked off at you about that. Something to talk about with parents is there is some impact on growth. There can be a slight reduction in growth velocity, but these children ultimately reach their normal predicted. Long-acting beta agonists is next. These are potent bronchodilators. They last 12 hours or more. They're highly specific for the beta-2 receptor. The long-acting beta agonists tend to have very low rates of tremor, palpitations, and tachycardia. They're good at reducing daytime symptoms. They're especially good at reducing nighttime cough. So if that's a predominant symptom for a patient, I'll often, add that on and give a little bit more weight to that rather than increasing the dose of the inhaled steroid. The LABAs are preferred add-on therapy to inhaled steroids for patients over 12 at step 3. And then they're an option at step 3 for the 5 to 11 group and an option at step 4 for patients under 5. So that's all in your guideouts. The long-acting beta agonists, again, they're not recommended as monotherapy. When salmeterol was being introduced, if you've heard of the SMART trial, that was the trial, salmeterol multi-center asthma reduction trial. Patients who were given salmeterol alone had a higher rate of death than those who were in the control group. Those patients were not on an inhaled steroid. The thought is that if you're using it without an inhaled steroid, you're only addressing the bronchial hyperreactivity. You're not addressing the airway inflammation and edema. So there was no increase in mortality if patients were on an inhaled steroid. This is why long-acting beta agonist alone is never correct in asthma. More patients died in the trial. Leukotriene receptor antagonists. Montelukast is really the only one we use. I guess if you're fancy and you want to prescribe Accolate, go ahead. But no, it cannot be given in young children. Montelukast, on the other hand, is approved above the age of 1. It's a once daily medication. It has virtually no side effects. It is extremely safe. It's an alternate therapy for mild persistent asthma, and it's an adjunct for step 3 and above. It's particularly effective for if there's aspirin-sensitive asthma, which you're usually not going to know about in a kid because we don't give kids aspirin. But it's also particularly effective for exercise-induced bronchospasm. So I tend to use this a lot in kids because of the low cost, and parents are really receptive to it because it's not an inhaler, it's not a steroid. Yes, question?
Yeah, so I see it a lot that we have these kids on inhaled corticosteroid plus a LABA. Can we also add this in addition to, or is it exclusively one or the other?
So you can look on your steps to see whether or not that would be indicated. In general, it's going to be inhaled steroid plus LABA or leukotriene receptor antagonist. Right? Even if you're looking at like step 5, inhaled steroid plus LABA. I have certainly seen patients who are on that combination. It's a little bit outside of the guidelines, but guidelines are guidelines. I think if you have a patient who really has a strong exercise component, a strong allergic rhinitis component, those patients often do really well with the addition of montelukast. And then real severe asthma, there are some additional options outside of what we routinely use in the office. There are biologics, Xolair, which targets IgE, and then there's 3 newer anti-interleukin 5 therapies for adults age 18 and up. This is usually going to be done in a pulmonologist or allergist office. I just want you to be familiar with them. These are step 5 and above therapies. All right, eye clickers. We're going to do a bunch of questions to help you put all this together. So, 2-part question to start. Question 1A, a 15-year-old asthmatic male presents with an episodic cough and wheezing. Currently, he is at his baseline and he is not wheezing. He reports wheezing episodes 3 to 5 times a week and nighttime awakenings about 3 times a month. He states that 6 months ago he had to go to an urgent care center for a URI with a severe cough, which was treated with an asthma inhaler and some oral medicine for a few days. He doesn't know what he took. His FEV1 is 70% of predicted. This patient has what? Intermittent, moderate persistent, mild persistent, moderate persistent, or severe persistent? All right, most of you guys got it. It is D. He is moderate percent. Now, what would be the preferred, notice I put preferred, long-term treatment for this patient? Short-acting beta agonist only, low-dose steroid, low-dose inhaled steroid plus long-acting beta agonist, low-dose steroid plus leukotriene receptor antagonist, or a medium dose steroid plus a leukotriene receptor antagonist. We are split between C and E, low-dose steroid plus long-acting beta agonist, or medium-dose steroid plus leukotriene receptor antagonist. Key here, as I said, what is the preferred treatment? The the addition of the long-acting beta agonist comes in at an earlier steroid dose in 12 and up than it does at younger ages. All right, question 2. A 6-year-old male with a past history of reactive airway disease has a 2-month history of cough and wheezing 3 to 4 times a week, requiring treatment with his albuterol inhaler. He also has nighttime awakening with coughing and wheezing less than once a week. Office spirometry reveals an FEV1 that is 85% predicted. Which one of the following is preferred therapy for this patient? Again, preferred. Know that there are alternatives, but we're looking for the preferred therapy. Okay, got just 8 answers so far. Let's go ahead and put your answers in. All right, good. Most of you have it. It is B, inhaled steroid. I did include some alternates that were okay, so montelukast. The other things that do show up as alternates are cromolyn, nadocromil, and theophylline. Those are much, much less effective. I really think that they should just update the guidelines just to get rid of all those, at least do that. But you're going to use your inhaled steroid first line. Leukotriene receptor antagonists like Singulair alone would be an acceptable alternative. Question 3. A 32-year-old patient has a history of moderate persistent asthma treated with a medium dose inhaled steroid. Over the past 3 months, he has awakened with a cough once or twice a month and has required the use of his albuterol inhaler once a week. Once in the past year, he had an exacerbation which required the use of an oral corticosteroid. His peak flow periodically drops as low as 540, down from a personal best of 600. Which of the following would be most appropriate? Okay, about half of you guys did get it. It is no change in drug therapy. So he meets all of the parameters for being well controlled. I made you do some math in there and determined that his peak flow only drops to 90% of max. So he's well controlled, so you don't need to add on any therapy. Medium dose inhaled steroid at this step is okay. You don't have to make a change to the preferred treatment since well controlled. Question 4. You see a 14-year-old female for a routine annual visit. She has a history of episodic wheezing in the past, treated with inhaled albuterol as needed. She tells you that she uses her inhaler less than once a week and rarely develops nighttime wheezing. Her FEV1 is 90% of predicted. She reports that at least twice during the past year, She had a persistent cough and wheezing which required urgent care visits and was placed on a short course of oral steroids. Which one of the following would be the preferred treatment for her? All right, we struggled with this one a little bit. Correct answer is B, C, low-dose steroid. I apologize. 4 of you guys got it correct, low-dose steroid. I meant to say low-dose steroid. Reason here is, so you're looking at current impairment and risk, right? Her impairment is just fine, but her risk is higher. She had 2 or more exacerbations requiring steroids in the past year. And when you're deciding where to go in therapy, you're always looking at the most severe component. So her risk places her at step 2 for therapy initiation. So she should be on a low-dose inhaled steroid. There's evidence that that's going to lower her risk of an exacerbation that would require hospitalization or inhaled steroids. So you should go to step 2 for this patient. Even though her current impairment's okay, her risk is not. Make sense? And this should be our last question. A 3-year-old child with a diagnosis of mild persistent asthma is brought in for a follow-up visit. The patient's mother reports that overall he seems okay. She gives him nebulized albuterol for wheeze or cough about 3 to 4 days a week on average. He wakes up with a cough at night about 2 or 3 times per month. She denies noticing him getting out of breath or breathing hard when he's active, and his activity does not seem limited. He has 1 exacerbation in the last 12 months requiring steroids. Currently, his only therapy is a low-dose inhaled steroid. What is the preferred therapy given his current presentation? You reduce him to just short-acting beta agonists, continue low-dose inhaled steroid, start a medium-dose inhaled steroid, continue the low dose and add a long-acting beta agonist, or continue the low-dose steroid and add montelukast. All right, we're pretty split. Us looking for C, the medium dose inhaled steroid. And yes, you guys are correct. You should step up his therapy because he's categorized. So he's at step 2 initially on the low dose inhaled steroid, and then he can be categorized as not well controlled when you look at his symptoms and his nighttime awakenings. And this leads to a recommendation to step up his therapy by 1. Medium dose inhaled steroid is recommended step 3 therapy in children age 0 to 4. And also, guidelines do recommend consultation with an asthma specialist in kids age 0 to 4 requiring step 3 therapy or above. I do tend to, if I've got kids that young where I'm needing inhaled steroids, I do tend to get a pediatric asthma or allergist involved because it is tougher to track these patients, and I view them as being at a bit higher risk. All right, so thank you all for your attention. Next week, there's going to be more. We're going to look at treatment of acute exacerbations. We're going to look at exercise-induced bronchospasm. Again, I wanted to really walk you guys through how to use the guidelines and really understand that more than just the memorization. Unfortunately, there's not like a great asthma app out there for providers. I was really hoping there would be one. I look every time I make this lecture again. But if you were to just simply, if you're looking for help with an answer and you Google like NAEPP asthma guidelines, you can really easily find this categorization and the therapy steps and use that to help guide your treatment. Keep that medication dose chart with you. I think that's a real useful one. There's a lot of different equivalency charts out there. Up to Date has that information pretty accurately, because we make a lot, I notice we make a lot of mistakes in dosing of medicines. I see a lot of patients that are just thrown on a high dose and never adjusted, especially adult patients. A lot of high dose Advair and never adjusted down. So, and I think that's because a lot of the controller medicines, they're just easy. Just start Advair, start Symbicort, and people don't really think about it. But you don't really want to over-treat with the steroids because there is some risk associated with them. So make sure you know where to find the guidelines, how to use them. I'm going to work on making this lecture available online if you want to review it all. Any questions before we're done? Oh, Dr. Lick.
When will inhaled steroids be cheaper?
When will inhaled steroids be cheaper is the question. I have no idea. They should be cheaper. They've been out for a long time. You know, there's new ones coming out, but you know, the older ones and some of the older controllers like Symbicort and Advair, they've been out for over a decade and haven't come down in price. Singulair did come way down in price. That used to be very expensive, and that's why I end up using it a fair amount in young kids. Other questions? Dr. Shamami.
Or just an announcement. Beaumont is about, with Beaumont insurance, it's about $70 for an inhaler. It's $19 in Canada.
Yes, Flovent, $70 on Beaumont insurance, $19 in Canada. I have multiple asthma patients that fill their inhaled steroids in Canada. There's a huge difference in price if you go across the border. Harrison, yes.
Canada mail your prescriptions to you?
Can Canada mail your prescriptions to you? I don't think they can. Robbie will smuggle them across the tunnel for you. Very good. Thank you.